All right, we're going to finish the neonatal chapter this time. Let's talk about sepsis. A 3-week-old infant presents with irritability, poor feeding. So again, these are two things that we saw with RDS. Temperature of 102 and grunting. We saw grunting with RDS. Physical exam reveals a bulging fontanelle, delayed capillary refill, and grunting again. I put that twice. That's important. Okay, so sepsis is a systemic response to an infection. And in newborns, we divide it into what we call early onset or late onset sepsis. Early onset sepsis means that it appears in the first 7 days, and late onset means that it appears from 8 days to about 28 days of life. So it's a classification system. What puts you at risk for sepsis? Neonatal sepsis, well, a maternal infection. So if mom had fever, mom had leukocytosis, a urinary tract infection, something like that, puts the baby at risk also. Prematurity will put the baby at risk for sepsis. Prolonged rupture of membranes puts you at risk for infection. And you need to know your common organisms. The most common bacterial cause of neonatal sepsis is group B strep. You have to know that. Okay? E. coli and Listeria are like distant second and third. And your initial choice of antibiotics will cover all three. But you're really going to bet on group B strep. Viral causes, think of herpes simplex. And you can think of enteroviruses too. Again, the signs and symptoms are very nonspecific. It could be grunting. It could be fussiness. It could be poor feeding, tachypnea, respiratory distress, apnea, bradycardia. Newborns, in this particular question, this baby had a temperature of 102. But newborns don't always have fever. In fact, sometimes they will present with hypothermia or temperature instability. So remember that when you're reading your question. Full fontanelle, well, that's more meningitis than sepsis, and that can be helpful. Babies, infants, if they have fontanelles, they usually don't present with nuchal rigidity because your fontanelle is like a pop-off valve for increased intracranial pressure. So remember that they may not have nuchal rigidity. So how do you work these babies up? Well, a CBC is helpful. You should make sure that they don't have meningitis, so a lumbar puncture is helpful, and do your CSF studies. Blood culture, urine culture, anything, any skin lesion should be cultured that you think is suspicious. A chest x-ray to make sure they don't have pneumonia. So it's kind of a shotgun approach, but you're looking for any focus of infection. The treatment will be with antibiotics, fluid management, and attention to details. So antibiotics, you have to know what your common germs are so you know what antibiotics to start with. And generally we will start with ampicillin plus a third-generation cephalosporin or ampicillin plus an aminoglycoside. And everybody worries with aminoglycosides and what? Nephro and ototoxicity. And so when you're on an aminoglycoside, you do need to follow levels on these patients, and you do hearing screens later. Okay. Supportive care is important, and you have to make sure that this baby, let's say, had delayed capillary refill, so probably needs a little bit extra fluids because you don't want them to have hypotension and get shocky. So that's when they need a little extra fluid. So you need to pay attention to those things. The rest is antibiotics and supportive care. Okay? Penicillin or ampicillin given at least 4 hours prior to the delivery will help reduce the incidence of early group B strep infections in the neonate. So give it to the mom at least 4 hours before delivery. Your differential, well, we talked about respiratory diseases. Differential includes respiratory distress syndrome, pneumonias. Congenital heart disease can present with grunting, tachypnea, and poor feeding and things like that. So it's very nonspecific, or it's like a generic symptoms. Also remember metabolic diseases, intracranial hemorrhages, and the torch infections. And we're going to talk about the torch infections in a minute, right now. Okay, torch is a mnemonic. It stands for toxoplasmosis. Other can stand for syphilis and varicella. The R is for rubella. C is cytomegalovirus, and the H is HSV, herpes simplex virus. Okay, let's talk about toxo first. Toxo is transmitted by ingesting undercooked or raw infected meat. If you live in France and you eat steak tartare, right, a lot of it, that's not a big item here, okay, you're at risk to get toxo. Steak tartare is glorified, ground up filet mignon, and you put all the stuff on it yourself and eat it raw. Okay? In this country, more commonly, you get toxoplasmosis from, no, that's not the right, you get toxoplasmosis from handling kitty litter or cat feces. So look for kitty litter or cat feces, and that's, in this country, how you're most likely going to get toxoplasmosis. The majority of these, when we talk about these torch infections, keep in mind the majority of these occur when you're infected in the first or second trimester. You can get the infection yourself, and it's very mild. The problem with toxo is if it's a congenital infection when the baby catches it through the placenta. Okay? What are we going to see? We're going to see intracranial calcifications. Again, the first or second trimester, you'll see 40% of babies will be infected if it occurs in the first or second trimester. Many babies may not have symptoms, but you will see intracranial calcifications. You can see intrauterine growth retardation, and it usually is symmetrical, which means you have microcephaly. These patients can have spasticity, seizures, blindness, and hepatosplenomegaly. That's what HSM stands for, hepatosplenomegaly. Your diagnosis, showed you here, you can isolate it from the placenta or the cord blood, or you can get IgM titers or an ELISA. The best test right now is the immunosorbent agglutination assay. The treatment, here we go, here you see right there, calcification, 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 calcification. They're spread all over the place. Look at all those white dots are intracranial calcifications. Okay? You can also see a retinitis. Most of these torch infections have very similar symptoms. So again, how are you going to tell toxo from CMV? Well, toxo, look for a history of the kitties, or kitty litter. Look for intracranial calcifications. The treatment is sparamycin for mom, and once the baby is born, you put them on pyrimethamine, and you put them on sulfa, and you're going to put them on leucovirin for the first 6 months because you're giving them a sulfa drug, so you want to decrease the problems with bone marrow suppression, so you're going to give the baby leucovirin. Steroids can be given for the chorioretinitis. CMV, cytomegalovirus. It's the most common congenital infection. Again, first or second trimester infection. Again, these babies have intrauterine growth retardation, so they're small for gestational age. They can have petechia, secondary to thrombocytopenia. They have hepatosplenomegaly, and they have a direct hyperbilirubinemia. When we looked at the differential chart, we saw that on the far side, all the torch infections basically. And you can culture CMV from just about anywhere, urine, blood, CSF, throat, or placenta. How do I tell CMV apart from toxo, for example? I look for the word periventricular calcifications because there's a V in it, same as CMV. That's how I remember it. Okay? Might work differently for you. You figure around. Okay? And again, look at all this stuff. This is a chorioretinitis that they get. And these, well, it's never good when you see a specimen of brain, right? Because they're not like doing brain transplants. So this is a non-survivor. And here is calcification. Here's a huge periventricular calcification. Okay? CMV, periventricular calcifications. You can also, diagnosis can also be made by culture or PCR, polymerase chain reaction. Okay? There's no treatment for CMV, and usually these babies don't do very well. They tend to have mental retardation, microcephaly, they can have liver problems, things like that. Varicella. Varicella can be divided into neonatal, which means that you're delivered less than a week before or after the onset of the maternal disease, or it can be congenital. The neonatal will be treated with varicella zoster immune globulin, and that's done if the mother develops the disease 5 days before to 2 days after delivery. Okay? 5 days before to 2 days after delivery, mom breaks out with chicken pox, the baby needs VZIG. Everybody gets acyclovir. Perinatal disease gets acyclovir. Okay? Congenital varicella, again, first to second trimester. Here's what you can see: limb hypoplasia, scarring, microcephaly, chorioretinitis. And again, the perinatal is 5 days pre to 2 days post-delivery. That's when you add the varicella immune globulin to the treatment regimen. Okay? And this is much more serious because mom hasn't had a chance to develop antibodies, so the disease really goes and messes up the child. Congenital rubella. Now, we can immunize against varicella now, so don't forget that we can prevent the disease by immunizing against varicella. So anybody here, how many people here have not had chicken pox? You're sure? There's one person. Didn't raise her hand that high. You need the vaccine. Have you had the vaccine yet? No. Tomorrow you go get it. Okay? Because you don't start till 6. So tomorrow you go get your first vaccine, and then about a month to 2 months from now you get another one. Okay? Very important, because you can get a lot sicker if then you can get this too. Okay? Don't worry, I'll be giving all of you health tips throughout the next few days too. Don't worry, I'll get you all. I won't even mention smoking, right? Don't get me started on that. I'll get to that. Okay. Congenital rubella. Congenital rubella occurs in about 80% of babies if the mom is infected in the first trimester. So all of the disease, all of these torches, think of first and second trimester, please. Okay? 80% of babies will be infected. And clinically they can have mental retardation, microcephaly, heart defects, cataracts, hepatosplenomegaly, and thrombocytopenia. The heart defects include PDA and pulmonary stenosis, but it can be any. Okay? They can also have deafness. They have what we call the blueberry muffin babies. Now, there's other things that can do this, but the typical one is going to be congenital rubella syndrome, blueberry muffin babies. And you can diagnose it by getting IgM titers and get immunized. Immunized prior to pregnancy. Okay? Anybody who's born after 1957, I suspect that's most of you here, should have had a second MMR. How many people have not had their second MMR? How many people should have a second MMR? Probably most of you who didn't. Okay? This is what we call the blueberry muffins. It's usually because these are purpuric lesions because of the thrombocytopenia, and then they get jaundice, so it looks like a blueberry muffin. So these are purpuric lesions. Blueberry muffins. Blueberry muffin. See, this one is jaundiced, okay? And actually has a pretty big liver. It's hard to see it on a picture, but it is, believe me. Okay? And they have a chorioretinitis too, all this stuff out here. HSV or herpes simplex, and again, you can prevent with immunizations. Or herpes simplex, you acquire it by passing through an infected birth canal. Okay? You can have primary disease, which is the mom is getting the disease for the first time. That means that there's no antibodies, which means that there's a lot of transmission to the baby. And then the best one to have, I guess, if you're going to say that, is the recurrent genital herpes, because mom has a lot of antibodies, so there's a lower risk of transmission. Okay? And remember, what do you do with the baby? Mom has got She's culture negative, no lesions are seen, you're absolutely sure you can deliver the baby vaginally. If there are lesions, you must deliver the baby by C-section. Now, that's not a 100% guarantee, but that's a lot better than going through an infected birth canal. The patterns of herpes simplex is going to be divided, and we call it into the local, which is also known as SEM, skin, eyes, mouth. And it presents at about 5 to 14 days of age. You have what's known as the disseminated form, which presents at about 1 week of age with pneumonia and shock, so they'll be hypotensive, tachycardic, delayed cap refill, and they can have hepatitis. And then the central nervous system disease presentation, which presents later on at 3 to 4 weeks, basically with like a meningitis, lethargy, seizures. They can have hemodynamic instability too. So you tap, let's say you have a baby that comes in at about almost 4 weeks old, fever, rule out meningitis, and the tap has only like 10 cells. Well, you should be thinking of herpes simplex with all these symptoms. Don't think, oh, the tap is clean. The tap is not clean. All right? Okay. This is, let's go to, the most common is going to be the skin, eyes, and mouth. And that's the best prognosis. Okay? So if you have the skin, eyes, and mouth, then you have a 94% of them will have normal development. Okay? Disseminated, only 59% will have normal development. And then the ones who present with CNS, only 36% will have normal development. That's pretty bad. And again, mortality is very high with the disseminated, especially if they have disseminated intravascular coagulopathy and a pneumonitis. That's almost uniformly killer. And SEM is the best to have. And always remember, C-section with intact membranes does not necessarily prevent always, but it's better, and that's what's recommended if you have active lesions. Okay? And here are some of the skin manifestations of herpes simplex. Right there. Okay, treatment is going to be with acyclovir. Syphilis. Okay? Syphilis is going to be divided into early and late manifestations. Syphilis can be transmitted at any stage of pregnancy. The early stage is going to be in the first 2 years of life. And the symptoms include fever. Well, a lot of babies get that. Anemia. A lot of babies get that. Failure to thrive. A lot of babies get that. Rash. Same thing. Snuffles. Now, they may have a couple of these things, and you have to put it together and just be suspicious because babies can present with a lot of these things. Snuffles is that runny nose that the baby always has. Okay? So you have a picture of Snuffles right there. Okay? See that glistening stuff? Okay? Well, that's not boogers. Okay? Those are treponemes. Okay? So if you're suspecting that, you better put on a glove. It'll be very hard to explain to somebody that you got syphilis from a baby. Right? Second stage. Second stage includes a skeletal manifestation. Now, in the early stage, you get a periostitis. Okay? That's about the only skeletal manifestation. But the late stage, greater than 2 years of age, that's when you see the saber shin, the Hutchinson's teeth. There's a misprint in the notes, I think. It should say saddle nose, not addle nose. Okay? So it's a saddle nose, and ragades are these fissures at the corners of the mouth. Okay? There's also, I throw in what's called as the Jarisch-Herxheimer reaction. Just throw it in because you may get a question where they say the baby has syphilis, you give them penicillin, they develop a rash and fever. Okay? This fever, it's not an allergic reaction to penicillin. It's that you're killing off it's a systemic reaction to all these treponemes that are being killed. Okay? So remember the Jarisch-Herxheimer reaction. And a diagnosis is going to be made by your rapid plasma reagent or your fluorescent treponemal antibody. You can do dark field on that on that snuffles, you can scrape that and do a dark field exam, and you'll see a lot of treponemes there. Okay? Okay, don't forget your Clutton joints with the synovitis. You see that in the skeletal manifestations. Oh, that's the periostitis. There we go. Okay. I did it again. Kind of put it in backwards. Okay. All right. All right, let's talk about some GI things, okay? Tracheoesophageal fistula. A newborn is noted to have choking and gagging with its first feed and then develops respiratory distress. Chest x-ray shows an aspiration pneumonia. A feeding tube is coiled in the esophagus. Okay? So that's a TE fistula. And there's various kinds of TE fistulas. The most common is where the esophagus kind of finishes into a blind pouch, and there's a little bit of a connection, like a fistula, between the esophagus and the trachea, and then distally. And so you will get air into the stomach because of that distal connection. Okay? So you've got a blind pouch in the esophagus, you've got a fistula from the trachea to the distal esophagus, you get air in the stomach just the same. And the baby will choke, cough, gag, and get cyanotic with the first feed and every feed afterwards. Why? Because it's aspirating. So that's a TE fistula. And there's other combinations, but that's the most common one. And when you put a feeding tube into the baby, it gets stuck in that coiled esophagus. It gets coiled in the blind esophagus. You should look for that history of coughing or choking. You should look also for a prenatal history of polyhydramnios. And it's a clinical diagnosis. You can't pass the catheter. You get an x-ray. You see air in the stomach and aspiration. And the treatment is going to be surgical repair. You should be looking for other abnormalities, however. If there's something wrong already, you should look for other things to be wrong, like congenital heart disease. They are much higher risk for congenital heart disease, such as a PDA or a vascular rings or coarctation. Also look for vertebral anomalies, anal rectal anomalies, renal, but really have a high incidence of suspicion for congenital heart disease. Okay, this is duodenal atresia. These are other gastrointestinal problems. This is a backwards duodenal. We're looking at them from the back. Okay? This is the double bubble of duodenal atresia. Now, with duodenal atresia, you're going to get a history of bilious vomiting from the very beginning. This slide needs to be fixed. This bubble should be on this side, and this bubble needs to be over here. I looked at them again today, and I still put it in wrong. Okay? So look for what's known as the double bubble of duodenal atresia. Look for bilious vomiting in the neonate, and there's a higher association with Down syndrome. Okay, that's okay. All right. The next one that we're going to talk about is Hirschsprung's disease. And again, Hirschsprung's should be suspected in any child, infant, newborn, that has not passed stool in the first 24 to 48 hours. Most babies will have stooled in the first 24 to 48 hours. If they haven't, you should be thinking of imperforate anus, you should be thinking of Hirschsprung's, you should be thinking of meconium plug, meconium ileus. Right? That's your differential diagnosis. Hirschsprung's, remember, it's also known as congenital aganglionic megacolon. There's no stimulation of nerve cells in that one little area, and everything else backs up. So if you get a barium study, this is the normal area. Here, this big dilated area is normal. It's this atretic area here where there's no stimulation that stays small, and then all the stool backs up. So that is the affected area. And the best way to diagnose it, the gold standard, is going to be biopsy. Okay? And you know how they like to ask, what's the next test? What's the best test? So they might tell you, you suspect Hirschsprung's. What's the best test? You should be looking for biopsy. And you will find an area that has no ganglion cells. All right? And the treatment is going to be surgical You take out that area. Later on, you anastomose them. If it's down here low, you may do an anal reconstruction even. And then necrotizing enterocolitis. Oops, sorry. This is Hirschsprung's, where they took out a resection. Here's the affected spot right here. And it is all dilated. This is the normal area. Okay, this is necrotizing enterocolitis. Now we go back to the APGAR, the first thing we talked about. Necrotizing enterocolitis, or NEC, is the most common medical and surgical GI emergency in the newborn. Look for a history of a preterm infant. Most of these babies are preterm. Look for a history of some kind of perinatal asphyxia. How do you know that? Low APGAR scores. Okay? Then you might have a history of the baby starts getting fed and starts having bloody stools, or starts to get distended, or they say lethargic. Okay? You start putting all that together, you should be thinking of NEC. And what you're going to see, what's the most appropriate test, that sounds like a test question, right? The most appropriate test would be to get an abdominal film. And what are you going to find on the abdominal film? Pneumatosis intestinale. Okay? And that's what you see here. This is air inside the bowel wall. Not in the bowel lumen, we all have air there, inside the bowel wall. So you have some right here. Here's some more. Here's some more. All of this stuff is pneumatosis intestinale. Okay? This is necrotizing enterocolitis. Here's some more necrotizing. Look at this one. Looks like a big old loop there. Look at that. Okay? I can talk all day about it, but it wouldn't work as well as you guys see in this picture. All right? And here it's so bad, it's moving up into the portal system. Okay? This is necrotizing enterocolitis. What do you do for them? Bowel rest, antibiotics, and sometimes surgery, because this can get so necrotic that you have to remove pieces of dead bowel. Okay? So that's NEC. Okay, neonatal seizures. In the newborn intensive care unit, an infant is noted to have sucking movements, tongue thrusting, and brief apneic spells. The blood counts and chemistries are normal. Well, they're giving you a lot of information right there because they're telling you that the chemistries are normal. Neonatal seizures, they don't necessarily present with generalized tonic-clonic movements like in older children or adults. And we have a list of seizures we'll get to in a second. So what can cause neonatal seizures? Well, you can have hypoxia. Hypoxic ischemic encephalopathy, it's the most common cause. Usually, the seizures will present at 12 to 24 hours after birth. An intraventricular hemorrhage, okay, look for a history of a preterm baby. Usually, those seizures present after 24 hours. They don't present right away in the first day. They present the next day or the day after. And again, IVH, think of respiratory distress syndrome or prematurity as up there as causing your intraventricular hemorrhages. In those babies, you might see a bulging fontanelle. Or, if you do a spinal tap, you may get bloody fluid that doesn't clot. That's important, because you get bloody and it's clots, means you've got a traumatic tap. But if it's bloody and it's not clotting, it could be an IVH. And you can ultrasound them or CT scan them. And you can have metabolic causes of seizures. Always, in pediatrics, we always hammer on the residents, you have to check a blood sugar. Hypoglycemia can cause these infants to have seizures. And that's easily correctable. And then hypocalcemia also. And always be suspicious for infections. We always worry about sepsis, meningitis, something like that, causing a seizure in the newborn. You have a list of the presentation of the seizures. Focal seizures, okay, rhythmic twitching, usually the face and the extremities. Multifocal clonic, in which a lot of muscle groups are involved. The tonic, where they get very stiff. You can have a combination of tonic, where they get stiff, and then clonic, where they shake, they jerk. The really important one to know is subtle seizures, the one that's presented in this question, the tongue thrusting, the apneic spells. That's what you're really going to see in a newborn. That's what you should be looking for. Diagnostic tests, Well, always check a blood sugar. An EEG may or may not show anything. A CT scan or an ultrasound of the head may show a bleed. That's true. But always right off the bat, you should get a blood sugar. And that's why in this question they said blood chemistries and counts are normal. I kind of let you know, okay, I've eliminated that as a cause. You may need to do other electrolytes, calcium, magnesium, phosphorus. Spinal tap or lumbar puncture helps to rule out meningitis, or if there's a bleed, it might show up that way. Ultrasound and CT scans. Okay? All right. Next page is you have maternal diseases that affect the fetus or the neonate. And you have a list there, cyanotic heart disease and its effect, Graves' disease and its effect. So I've made it into a table. I can't explain it any better than that. You need to know those. Same thing with drugs that affect the neonate. A lot of drugs affect the neonate. We've streamlined them to, like 1, 2, 3, 4, 5, the top 5. I just passed the Letterman Theater, right? So Dave's top 5 list. Maternal drugs affecting the neonate, but there's a lot more. And the teratogenic drugs. You definitely need to know alcohol and fetal alcohol syndrome, and we'll show you that the last day. We'll show you some pictures. Absolutely have to know isotretinoin. Okay? It can cause facial and ear anomalies and congenital heart disease. Any female of childbearing age who is going to go on isotretinoin for their acne needs a pregnancy test and needs to be told not to get pregnant. Okay? Phenytoin can cause what's known as they have particular or characteristic facies. They have hypoplastic nails. They have what's known as the Cupid's bow mouth, so that their lips look like a bow and arrow, Cupid, Valentine's Day. Remember stilbestrol, it's coming back. Okay, thalidomide is really coming back, right? Thalidomide is being used a lot and can cause limb abnormalities, so remember that. And tetracycline is not recommended because even moms taking it and then the baby, when their teeth develop, they can have enamel hypoplasia. Okay? All right. So I told you I'd get you out of the newborn. Spend some time on resuscitation now. All right. Chapter 2. Ready? You are called to attend the delivery of a 22-year-old G1 P0. She's delivering. Does this need to be spelled out? Oh, sorry. I'm reading the author's notes. She has been followed in the prenatal clinic and all cultures are negative. The patient is termed with a single gestation. However, meconium is visualized. So resuscitation, especially of the neonate. The neonate, if it's just being born, this baby's past medical history is what? It's the mom's history. Okay? So you need to ask, is she on any medications? Because if she just got something to knock her out, most likely the baby's going to come out depressed. You need to ask how many babies are in there. Okay? Because maybe there's 2. You need some help. You only got 2 hands. So you need to ask questions about the mom's, the prenatal history. That's the baby's past medical history. All right. So resuscitation in the neonate include twin gestation, prematurity, and meconium. We already talked about suctioning the mouth and all in meconium. In children who need resuscitation, usually it's accidents or illnesses, particularly respiratory disease. The majority of codes in children are respiratory. And if you can get an airway, you can bring them back and be a real hero. Okay? Very few children have cardiac events. The death rate is much higher from cardiac events. Respiratory events, you put an airway in and you can fix the child. The best place to have a cardiac arrest or a cardiorespiratory arrest is where? In the NICU? No. The show ER or in a real ER? No, the best place is actually on TV. Okay, the best place to code is on TV because they have like over a 90% save rate. because if you die at the beginning of the show, it's over. Okay? And actually, there was a study done in JAMA where they looked at that, and they have like an over 90% save rate on TV codes. People expect us, physicians, expect us to have as good a code rate or return them, getting them back as on TV. That's not going to happen. Okay? So if you want to have your heart stop, have it stop on TV, on a set of a TV show. Okay? Other than that, maybe Seattle, where everybody knows CPR. Okay? All right. Depending on what happens, the babies, they can present with apnea, they can present with a lot of respiratory distress. It's just a lot of, it varies depending on what's going on in children. But also just remember that in children it's usually a respiratory thing. You're not going to get a lot of resuscitation questions, I suspect. Okay? This is not a PALS course here. The physical exam varies with presentation. There may be an absence or decrease in respiratory effort, or the baby or the patient is breathing real fast and a lot of respiratory distress. Or they may be shocky because of their cardiac output is low. So they may have delayed capillary refill. They may have a high heart rate. They may be hypotensive. Always remember, hypotension is a bad sign because you have already used up your compensatory mechanisms, catecholamine releases and things like that, and now you're starting to lose your blood pressure. So that's a bad sign, hypotension. Okay? You need to know normal heart rates, and there you have a list depending on the different ages. And that's another important thing to know. Again, pediatrics versus adults. In children, the younger you are, the faster your heart rate, the faster your respiratory rate, and it progressively goes down. But what you might think is a high heart rate or a high respiratory rate for an adult may be normal for that age group child, so you need to know those. There are not a lot of diagnostic tests made for resuscitation. You can get blood gases and stuff like that. Generally, it's a decision of, I need to intubate, I need to do chest compressions. And always remember, treatment is A, B, C. Airway, breathing, circulation. Take care of those. Airway, you need to decide, is this airway clear? Is this airway maintainable or unmaintainable? Do I need to intubate? Or do I just need to do bag valve mask ventilation? Or do I just need to manipulate the airway a little bit? Breathing, quality of respirations, respiratory rate. Is there cyanosis? Is there nasal flaring? Is there retractions, grunting? And in circulation, again, heart rate, blood pressure, skin color, cap refill, urine output, level of consciousness. Those are all things that you look at when you're assessing the child. In infants in particular, always remember temperature. You could be working on this baby and it's not getting any better, and it's because the baby's cold. So try to maintain normal temperature in these babies. Okay, we talk here newborn for intubation. Use a blade 0 or 1, and the right size tube is about a 3. If it's a preemie, you go smaller. You do have an equation there to calculate the tube size in older children. You take their age in years plus 16 divided by 4, and that gives you pretty much the endotracheal tube size that you need. And in children under 8 years of age, it's generally recommended that you use uncuffed tubes. Older than 8, you can use a cuffed tube. Something also important is children less than 1 year of age. You do not do a Heimlich maneuver if you suspect a foreign body. First of all, you don't do blind finger sweeps on anybody. You have to, if you see the thing, the foreign body, and you can get it, fine. But if you don't see it and you suspect it, you can't go in there because you might end up pushing it farther down. So in infants, we do not, under a year of age, in children under a year of age, we don't do Heimlich maneuvers because you can cause blunt abdominal trauma. So we do the back blows. Okay, we put them kind of face down and hit between the scapula. In older children, older than a year of age, a Heimlich maneuver is acceptable. Okay, and then the last page of this chapter basically again goes through maneuvers such as airway, breathing, circulation, and your heart rates and compressions and all. Okay, you're probably not going to get a lot of that. Breastfeeding. A nursing mother asks if her 3-month-old baby requires any vitamin supplementation. What do you tell them? 3 months old, does it require any vitamins? Why not? Any iron? No iron. No fluoride? No. No. Good. Not at 3 months. No vitamin D? Why not? Why do they make these things then? Later. Maybe later you can have them, okay? Maybe later, yeah. Okay. So, they always say breast is best. Human breast milk is the best thing that an infant can have. We recommend that you use it exclusively for up to 6 months, at least 4 to 6 months, and then use it plus baby foods up to a year of age. And at a year of age, we tend to go off the breast and onto whole milk. Okay? So human breast milk is the best thing you can have. It offers quite a few advantages. We don't worry about these caloric requirements right now. Quite a few advantages. It's pre-mixed. Okay? You don't have to go mix it and run it with some water or anything like that. Okay? It comes out at the right temperature. It's always ready to go. Okay? So that's a great advantage. You don't have to sterilize it. It's warm at the right temperature. It's perfect. Okay? And so it's convenient. No sterilization is required. It does promote bonding. That's not to say that you're a bad mother if you don't breastfeed, okay? I don't want to give that impression. But it does promote bonding. There's a possible increase in your IQ, okay? A few points. Maybe the difference between medical school and law school, okay? We should do a study, okay? It's designer, okay? Human breast milk is made for humans, so it's absorbed better, and it does give you protection from allergens. And breastfed babies have a much less risk of obesity versus formula-fed babies. So this slide pretty much summarizes that paragraph, all right? It's pre-mixed, right temperature, concentration, has immunologic factors like IgA, lactoglobulins, and maternal macrophages. Breastfed babies it's documented, have a lower incidence of upper respiratory infections and otitis media, and less problems with allergic diseases. Now, what are the mom's advantages to this? Well, you know it is not contraception. It is not a contraceptive method. You need to know that. I've had several patients. I had, a mom who her kids are like 10 or 11 months apart because grandma told them it's okay. It is not a contraceptive, okay? But it does allow you to return to your preconception weight a lot faster. If you're breastfeeding, you're losing an additional 500 calories a day just by nursing. Okay? You're already losing calories cleaning up after your dirty husband and, and all the other kids and stuff. So you're losing calories just by doing that. You're also, you have your uterus regresses to its normal size a lot faster because what lets down the milk? Oxytocin. What do you use for uterine contractions? Oxytocin. So it has those advantages right then and there. Okay? And again, the maternal-infant bonding is promoted. What are the advantages for the dad? He can sleep all night? No, you can express and give it. He can give it to the baby if it's necessary later on in life. So you don't get off with that, okay? So there are definitely advantages for the baby and for the mom. Supplementation. Okay? Vitamin K is going to be present in breast milk. And again, I need to go back into newborn. Part of routine newborn care is administering vitamin K. It helps prevent hemorrhagic disease of the newborn. When the baby is first born, vitamin K levels are low. How do we get vitamin K? Well, we have bacteria in our gut that make vitamin K. Well, these babies are born and they don't have a whole lot of bacteria in their gut just yet. So to prevent hemorrhagic disease of the newborn, which will be manifested as GI bleeding, occult bleeding, and we give them vitamin K. 1 milligram intramuscularly takes care of it. Breast milk has a little bit of vitamin K in it, so they'll be getting some as they go along. Fluoride is recommended after 6 months of age. Breast milk is low in fluoride, and even though the teeth haven't come out yet, you do need it. for the development of the teeth. Fluoride is also recommended if you are using ready-to-feed formula. Ready-to-feed formula has no fluoride in it. And you need to know if you are giving your baby formula and mixing it with water, you need to know what your local water supply has. If there's fluoride in the water supply, you don't have to supplement with fluoride. Okay? Vitamin D, if the mom does not have adequate vitamin D intake, you should probably give the baby that. But usually you make vitamin D by being out in the sun from your own skin. So unless you're in a cave, you probably don't need much vitamin D supplementation. Okay? And then we usually start iron-fortified foods at 4 to 6 months of age. There are few contraindications to breastfeeding. I'll leave that up, but you pretty much have the medications listed here. And this is not an all-inclusive list by any means. But the point is that the list is small. Contraindications to breastfeeding include active or untreated TB. So you need to know that. Syphilis, do not breastfeed. HIV, do not breastfeed. Galactosemia, we already mentioned. Varicella, do not breastfeed. Herpes is a contraindication only if there are active lesions on the breast. Otherwise, you can go ahead and nurse. Few drugs are contraindicated, and again, we don't have an all-inclusive list, but these are some of the common ones. We have what are known as absolute contraindications, and we have relative contraindications. We have antineoplastics, so chemo. Radiopharmaceuticals like iodine. The alkaloids, atropine, lithium, chloramphenicol, cyclosporin, nicotine, alcohol. Now, relative contraindications, now you have to sit there and go, well, maybe, maybe not, include seizure medications, neuroleptics, sedatives, tranquilizers, metronidazole, tetracycline, sulfa, steroids. These are all relative contraindications. Mastitis, and this is a common question, okay, mastitis is not a contraindication to nursing. In fact, we encourage that you nurse through a mastitis because it actually helps get you better faster. And you can take your antibiotic and still nurse. The baby won't have any problems, and it kind of helps you get better faster. And that's a common question that moms have, and that's a common test question too. Okay, formula feeding. And you have these medicines. You don't need to. Formula feeding is used as a substitute or to supplement. And the majority of formulas are cow's milk based, and then they fix them up to try to make them as close to breast milk as possible because they know that that's what the baby should be having. So anything that they find in the breast milk, they try to get to put it into their stuff too. You need to know that the common run-of-the-mill ones are 20 calories per ounce. And we do have some specialty formulas. Whole cow's milk. Like it says there, it's good for baby cows and anybody over a year of age. There's a higher risk for allergies. There's a higher risk of having GI blood loss and anemia. They don't absorb the iron as well that's in the cow's milk, and again, they can have GI blood loss. And it's very common to have a baby come in with a hemoglobin of 6, and you say, well, how long has he been? Now he's like 13 months old. His hemoglobin is 6, and the first question you ask, how long has he been on cow's milk? Oh, since he was 4 months old. That explains it right there. Okay? Whole cow's milk also has a very high solute load on the kidney. That's not good. The kidneys can't handle it. Look over here. 87 in human milk, 90 milliequivalents per liter, 226 in whole cow's milk. Not a good thing. Not good at all. Okay? And you have a table there with the comparison of human milk and cow's milk. Kind of breaks it down. Vitamin D is recommended. Again, if the formula doesn't have it, most formulas do. Again, just get out in the sun and you'll be fine. Goat's milk. You need to know goat's milk, you have to supplement with folic acid. Iron, we have foods. 6 weeks of age, if if it's a family that you know that there's no good iron intake. But generally, once you start them on cereals and stuff, you'll be fine. Solids. Solids should be introduced at around 4 to 6 months of age. The baby can first of all hold its head up. Its suck-swallow mechanism is better. It's at lower risk for allergies. And the key about solids is introduce one new solid at a time, one a week, so you know if the baby likes it or not, you know if the baby's allergic to it or not. Okay, two more concepts. One is colic. A mother states that her infant has been having episodes of inconsolable crying every night for the past 5 nights. He draws his legs up and his abdomen becomes rigid. The episode resolves as quickly as they come on, and the rest of the day he acts normally. Well, usually it starts at around 3 weeks of age and then lasts till about 3 months of age, and nobody really understands it. It's a cramping thing that happens. These babies then cry, they swallow air, they get more cramping, they pass gas, they draw their legs up. Generally, rhythmic motions help. So patting the baby, bouncing the baby, going for car rides, things like that help. Sometimes you can use anti-gas medicines like simethicone, and that helps. It typically occurs at the same time of night, like usually in the evenings around 7 to 10 or 8 to 11 or 9 to 11, things like that. Okay? There are no diagnostic tests for it. Again, gentle rocking and maybe some simethicone helps. And they outgrow it. Okay? Differential diagnosis is listed there. Intussusception, not as likely in that age group, but it can happen. Hernias, strangulated hair. They can have a hair around their toe or something, and it's cutting off the circulation. It hurts, and they cry. So you need to check the baby top to bottom. Okay? And the last thing on nutrition is protein-calorie malnutrition, or kwashiorkor. A 3-year-old boy is seen for chronic illness. He appears edematous and apathetic and thin hair. Generalized dermatitis is noted. Sparse hair and decreased muscle tone is noted. And so the name it describes it. Protein-calorie malnutrition. So they're not getting enough calories, they're not getting enough protein. Okay? So it's a severe protein deficiency, inadequate caloric intake, and they many times will have associated vitamin deficiencies. Usually it occurs after they wean from the breast, because now they're not getting the nutrition that they should be getting. So you're basically going to see this in poorer societies. They can be lethargic, apathetic, they don't care what's going on. They can be very fussy. Muscle tone is lost, and they lose subcutaneous tissue. They can get edematous because they lose protein, and so they lose oncotic pressure. And they can have dermatitis and sparse hair. You will notice a decreased serum albumin. Blood glucose could be low, as well as the essential amino acids. The treatment is going to be slow feeding. You don't want to replace it right away. They're not used to this, and that can be worse. So you give them slow feedings and slowly bring up their calories and their protein intake and give them vitamins. And even so, they can do poorly because if it's been going on for a long time, they have a lot of problems as far as developmental delays and actually recovering. Okay? So mortality can reach 30 to 40%. And then you have a table with vitamin deficiencies and what happens when you don't have them. So vitamin A, remember, you don't see so well at night. Thiamine, beriberi, niacin, pellagra, and you have your list there. And before we go on to the next chapter, I just want to, one other point on nutrition, which comes up very frequently, is no honey recommended in the first year of life because there's a higher risk of infantile botulism. Okay, so no honey. And remember that botulism usually presents as a descending paralysis. So when you're reading your question, you think, is this Guillain-Barré or is this botulism? Guillain-Barré is an ascending paralysis, and botulism is descending. So remember that. Okay. We're going to do some growth. And when we talk about growth, we talk about disorders of height and we talk about disorders of weight. And when we classify the height disorders, we're going to talk about short stature and tall stature. And when we talk about weight, we'll talk about failure to thrive and obesity. Okay. So when we talk about short stature, a father is worried that their 13-year-old son is short. The child has been very healthy. He is below the 5th percentile for height and has been all his life. Physical exam is normal. Father is 6'3". Mother is 5'10". Father's a little worried. Father was a late bloomer. Father's checking out how tall is the milkman, how tall is the mailman. Okay, he wants to know. And he was a late bloomer, though. So this is an important. There's a lot of information in these questions, and you'd be surprised how much information you can glean from all these questions. Whenever you're doing a question in pediatrics, it's very important to know ages, because when you go look, you read and you say this age, then you can start formulating a differential diagnosis for that age. It's also obviously important to know the sex, because then you can say, well, he's not pregnant, right? You can eliminate that from the differential. So it's very important in this particular case that both parents are tall, and it's very important to read that father was a late bloomer. Okay? Remember that growth, that he didn't grow, he didn't have his growth spurt till late in age. The question was, what does late bloomer mean? It means that he did not have his growth spurt till a little bit later than usual. Okay? So growth involves a change in size and form. When we talk about development, we'll talk about function. So growth means an increase in size and form and biologic maturation. Cells get bigger and you get more of them. We also need to remember, and we're going to show you some growth charts. We're going to draw some growth charts. And that's the basic part about this talk about growth, is you need to know your growth charts. Okay? So let's do some growth charts. And then we'll get back to the text. When we talk about the growth charts, you'll see, and you've seen them all, I'm sure you've all seen growth charts. They'll look like this, and we'll put height or length. Okay? And we call it length until they're old enough to stand, and then we call it height. And then we'll put the age here. And when we talk about weight, we just change it and we put the weight and the age. Okay? And growth charts, pretty much, you've seen them. They go like this, like that, and we might even put one in the center, like that. And the 50th percentile is the center one. And then we have basically a statistical definition. Greater than 2 standard deviations above the 50th percentile is the 97th percentile. And 2 standard deviations below the 50th percentile is the 3rd percentile. So that's a huge range of what we call normal. The 3rd to the 97th percent. It takes a lot to not be in the normal range for weight or height or head circumference or whatever. When we talk about disorders of short stature, we're going to talk a little bit about the differential and the workup and all, but you need to know basically these 3 growth curves, and they'll describe 3 different entities. We have, for example, if we have, in this particular case, the dad is 6'3" and the mom is 5'10", but the child has been low all the time. Let's put him like this. And it's very important, the more points you have, the better. If you only have 2 points, it's very hard to make a determination, but the more growth points you have, the better. So this child has always been low, and this is the age in years. And then, all of a sudden, he does that. This is the late bloomer, okay? He did it later than most children do, but he ended up in the normal range. So what do we call that? Constitutional growth delay. So you need to know what this growth curve looks like. And it may not be necessarily below the 3rd percentile. It might be at the 5th or the 10th. But there's a child that's low, low, and then all of a sudden, a little bit later, goes up. Okay? So that is constitutional. Now we have another child. And it's hard to do them all on the same graph, but we're going to try it. So there's a completely different child. Completely different parents. So now I tell you that that child, his father is 5'6", mom is 5'1". The tallest person in the family is 5'7". So what do you call that? Familial short stature. He is short because everybody else is short. It runs in the family. So that's familial short stature. So that's an important curve that you need to know, because they might throw growth charts like that at you. Okay? And then there's the third one, and we'll put them even. Let's go up here. Okay? Now what's that one? This is somebody you got to really be worried about. This is the one that could have the differential diagnosis of a pituitary tumor, a craniopharyngioma. Okay? Or if this is a girl, maybe this is a Turner's. Okay? So now you have to go through your differential diagnosis of what's causing, because this person fell off the growth curve. Okay? Those are the 3 major curves you need to know. So the one that's low and goes up to the normal range, that is constitutional delay. Then there's the one that's always low, but the family members are low. So that's going to be familial short stature, and that's where the history is important. And then there's the one that's falling off the curve, going across the percentiles, and that is the pathologic one, the one that you have to really find out what's going on. Okay? Those are the 3 major curves you need to know. All right. So you have, again, risk factors and etiology, 4 basic patterns: constitutional, familial, and prenatal onset, and pathologic. Prenatal means like an SGA baby. Pathologic short stature and constitutional short stature both start out with patient in the normal range for height, or at the low. Constitutional. They will reach their adult height, the constitutional, eventually, just the late bloomer, whereas pathologic will fall off. Again, if past a history of family members is important. And the more points you have, the better. Okay? What actual tests can you do? Well, a physical exam might be helpful if there's a syndrome associated, like, for example, Turner's. Any female that's going to be evaluated for short stature, you should be thinking of Turner's. And on the exam or in real life, you're going to probably see some physical stigmata of Turner's. Labs. Well, a CBC may be helpful. A urine, well, if you do have some renal problems, a urinalysis might start something, and then you get like a BUN and creatinine, and that might show you something, because chronic disease, renal diseases do contribute to short stature, so they are helpful. Liver function tests, thyroid studies. Don't forget hypothyroidism. And you may want to get a growth hormone measurement. And, of course, in the female, if you're considering Turner's, you should do a karyotype. Wrist films that tell you the bone age. So you get a film of the wrist and you're looking for a bone age is very helpful, because if the bone age, let's say the patient is 12 years old and is on the short side but has a bone age of 9, then you know that there's room for that patient to grow still. So bone ages are very important. And if you suspect, again, we mentioned pituitary craniopharyngioma, a skull film looking for a big cella turcica is a nice screening test if that's what you suspect. Okay? Treatment, well, you need to correct the underlying disease if there's one present. And growth hormone will help some patients. And your differential includes hypopituitarism, deprivational dwarfism, meaning you're not getting calories or nurturing, basically. Turner's, hypothyroidism, and chronic disease are the top ones on your list for differential. Tall stature. The majority of patients who are tall are normal. Okay? I am 6 foot tall. My wife is 5'9". My brother, my dad used to be 6 foot, but he's getting older. He kind of. My brother's 6'3". My brother-in-law is 6'3". My father-in-law is 6'5". Okay, so my son is at the 90th percentile for height. If he could only jump and dribble. Okay, and my daughter's like at the 75th to 80th percentile for her height. So I have tall children because we have tall genes in the family, and that's the majority of tall people. Okay. I guarantee you there's probably not a single NBA player who's got Marfan's. They're just tall. And that's the majority of people who are tall. That's the reason. Okay? But we do have other causes. Endogenous obesity. Okay? Or exogenous, I'm sorry. Obesity causes you to be taller too. Endocrine causes include growth hormone excess. And remember, we divide it into gigantism and acromegaly. Acromegaly is the one that the epiphyses fuse, and then you just have the big hands and the jaw and stuff like that. Androgen excess. Usually they're tall as children, but then it catches up to them, and they'll be short as adults. Hyperthyroidism also can cause tall stature. And there are genetic syndromes, and there are metabolic disorders that can cause tall stature, but these are the exceptions. Some of the syndromes include homocystinuria, cerebral gigantism, also known as Sotos syndrome, Beckwith-Wiedemann, Weaver-Smith, and Klinefelters. Okay? All of these are associated with tall stature, but these are the exceptions to the rule. Okay, disorders of weight, failure to thrive, and obesity. A baby weighs 16 pounds at 1 year of age. His birth weight was 8 pounds. Parents state that the baby feeds well. Physical exam reveals a baby with little subcutaneous fat, long, dirty fingernails, impetigo, and a flat occiput. Now, I'm very suspicious about this child. Okay? So failure to thrive means that you're not gaining weight appropriately, or that you're losing the rate of weight gain. Right, so if you see somebody who's off the growth chart for height, that is not failure to thrive. That's short stature. Failure to thrive is a weight problem. And that is a patient that has fallen off the curve, like we've shown for height, or is just not gaining weight as quickly as they should. And that can occur from malnutrition, and that can be that the parents are not giving this child enough because they can't afford to, or they don't want to, or they don't know to. Okay? It can be from malabsorption due to infections or celiac disease or chronic diarrhea for whatever reason, from allergies, immune deficiencies, and chronic diseases. And again, your growth chart, your weight charts are really helpful. The more points you have, the better to make the diagnosis. Please remember that your birth weight, in this particular case, I'm reading this question, and I know that that's not normal. Why? Because I know that a baby will double its birth weight by about 4 to 5 months. And by the time they're a year old, they should have tripled their birth weight. Well, this baby has only doubled its birth weight at 1 year. So there's something wrong. What else do I know that's wrong with this baby? Well, he's got impetigo, he's got long, dirty fingernails, he's got a flat occiput. That means that he's not being taken care of. He's not being cleaned. He's not being cared for. He's just laying there, and his occiput is flat because he's laying on his back all day long. Nobody's picking him up. Nobody's playing with him. This baby is being deprived emotionally and of calories probably. How do you diagnose this? Well, hospitalization is sometimes necessary. If a nurse can't put weight on the baby, there's something wrong with it. Okay, you put this particular patient in this question into the hospital, and you start giving them food and tender, loving care, and you watch this baby start to gain weight. Okay, so hospitalization may be necessary to document how many calories they're getting, to teach the parents to do it appropriately, to get them the resources that they need to feed the baby. Okay? In patients that are not gaining weight, even after you do all this, you should consider doing a sweat chloride test for cystic fibrosis. Okay, obesity is the opposite. Obesity is a generalized excessive overaccumulation of fat. And generally, obesity is because we eat too much and don't exercise enough. This is a 2-year-old. Okay? And if the parents are given, many times a fat baby's a healthy baby. Or every time the baby is an infant, every time it cries, it got a bottle. So the baby gets used to more calories. Okay? So it's a matter of whatever the cause. Usually, now some people who are overweight tend to have more adipocytes and bigger adipocytes. Okay? But the treatment is still the same. It's going to be diet and exercise. Very rarely do you see that it's a, grandma would say, a glandular problem. Okay? There are some syndromes associated with being obese and overweight. That's true. But those are the exception to the rule. Most of the time it's our own fault. We eat too much and exercise too little. Okay? So risk factors: parental obesity, family inactivity. Everybody's got remotes. Everybody just plays Nintendo, right? Ooh, I shouldn't use brand names. Everybody plays video games, okay? And so you just sit there. That's another cause. Feeding babies as a generic response to any crying can lead to obesity. Too much fruit juice has been implicated in the first year of life, has been implicated. And again, there are some syndromes. How do these babies present? Well, this child is tall because of the obesity. This child is very tall for the obese. So they can have tall stature. Boys may have increased adipose tissue in the mammary area, and it looks like gynecomastia. They can have abdominal stria. The fat pad in boys, the pubic fat pad, makes it look like a micropenis. Many times you will see that as a finding on physical exam. Okay? And you can do body mass index. Use your, which is greater than 95%, and there are curves for this, or a body mass index of greater than 30, and that's going to be your weight divided by body surface area, things like that. That's how you can figure out, but that's an easy one to figure out. The treatment, again, be dietary, changes in your diet, changes in your activities. Complications, well, obese children are at increased risk for becoming obese adults, and then you have the complications of hypertension, hyperglycemia, stroke, things like that. Okay? They can have, in adolescence, that's as an adult. As adolescents, they can have cardiovascular problems. They can have slip capital femoral epiphysis, which we'll talk about later. And they can have sleep apnea. And the differential includes endocrine causes, which are listed there, and also genetic causes. Again, most of the time, it's none of those. It's just that we're overdoing it. Okay. Fluids and electrolytes. We're going to go over some of these things. I'm going to leave the problems. That's your homework assignment. You have some fluid and electrolyte problems to calculate the amount of fluids that the patient should have. It's not a common question. How much fluid do they get? But I do want to go over over what maintenance is, and I do want to go over calculating the deficit and what fluid and what are your signs and symptoms of patients that are dehydrated, because you'll need to know that. Okay? So, a 7-year-old is admitted to the hospital for an elective tonsillectomy. The surgeon has requested the pediatrician to keep the child MPO after midnight. The child weighs 22 kilos. So all you have to do here is figure out maintenance IV fluids. So you want to calculate it from caloric expenditures. That's how you figure out what your fluids really are. And what we want to do for maintenance IV fluids is we want to replace what you would normally lose during the day. Okay? And what are your losses? Your losses are through urine. What else? Sweat, breathing, and stool. So we can pretty much measure the urine, pee in a cup, every time you measure it. That's a sensible water loss. The insensible water losses are how much you sweat or perspire and how much you breathe out. If I were to take a mirror, okay, that's loss, and stool. And that's been done, and we've figured it out for different weights and body surface areas, and so now we don't have to think about it each time. We just know what it is. And it says here, electrolytes are also lost in the urine, and you lose about 2 to 3 milliequivalents per kilo per day of sodium and about 1 to 2 milliequivalents per kilo per day of potassium. So we want to replace that. And that tells us what kind of fluids to use. So we know what our losses are. That tells us how much to use. We know what our electrolyte losses are. It tells us what kind of fluids to use. And to make it a lot easier, we say that for the first 10 kilos in children, we like to use 100 milliliters per kilogram. So if you have a 5-kilogram child, it's 500 cc's for the day. After that, for 11 to 20 kilos, you're going to start out with 1,000, because you can have 1,000 for the first 10 kilos, and then you're going to give 50 per kilo from 11 to 20. Greater than 20, then we will give 1,500, and then we give 20 per kilo for every kilo over 20. So this particular child that weighs 22 kilos, to calculate the maintenance dose, the maintenance fluids, we give the first 10 kilos is 100 per kilo, that's 1,000. The next 10 kilos is 500, so we're starting at 1,500. And the next 2 kilos is 40, so he needs 1,540 milliliters in a 24-hour period. Divide that by 24, and that tells you the IV rate. Okay, pretty easy? Okay, very easy. And then you have to calculate your sodium requirements and your potassium requirements based on the kilos, and that tells you how much to put in or what kind of fluid you want to order. Do you want to order half normal, quarter normal, third normal, things like that? Okay? All right. So that's easy. How about deficits? Deficits we have to calculate. Deficits can be calculated based on the physical exam or if you have a recent weight. So if you know that a child that weighs 10 kilos normally, he was in your office last week for a routine visit, and he weighed 10 kilos, and now he comes in 1 week later with diarrhea, and you weigh him on the scales, and he weighs 9 kilos. Well, you know he's not taking any diet drink. He's not trying to lose weight. That is his fluid loss. He's gone from 10 kilos to 9 kilos. He's lost 1 liter of fluid. That's his deficit. That's easy if you have recent weights. More often than not, you don't have a recent weight. You have the actual weight in front of you today, and then you have to calculate the percent dehydration and work your way back to what his normal weight should be, and then you can calculate your deficit. Okay? So, the deficits or dehydrations are usually divided into 3 types. We have isonatremic or isotonic, we have hyponatremic or hypotonic, and we have hypernatremic or hypertonic. The amount of deficit is going to be mild, moderate, or severe. In an infant or small child, mild is 5, moderate is 10%, and severe is 15%. In an older child or adolescent, we use 3, 6, and 9. Why? Because older children have less proportion of body water to their total weight. Right. And you have a table here that tells you what your physical findings are as far as mild, moderate, or severe. And you see that the milds don't show a lot, but a mild will have a thirsty and alert patient. they won't have tachycardia. Tachycardia presents with moderate to severe dehydrations. Pulses are okay in mild. They start to get weak in moderate and can be very weak in severe. The perfusion, that is basically what we call our capillary refill. So you kind of press on the skin and count 1 Mississippi, 2 Mississippi, how many seconds it takes to fill up again. So your perfusion is normal in mild and in moderate and starts to become reduced in the severe, and actually you start getting mottled. We showed modeling look in the infant. Skin turgor, fontanelle, these are all things that you can use to determine the degree of dehydration. And once you've determined the degree of dehydration, you know your deficit. You can, if you say, and I'll use the example again, this child weighs 9 kilos now. He's 10% dehydrated. That means that he normally weighs 10 kilos. And my deficit is the difference. And that's how much I have to replace. The important part now is how fast do I replace it and with what fluids? You always treat shock. If the patient is bad enough that they're hypotensive, tachycardic, delayed cap refill, things like that, you always treat shock by giving 20 cc's per kilo of normal saline or Ringer's lactate. You can't go wrong with those. I prefer normal saline. And then you decide what you need to do next. With isonatremic and hyponatremic dehydrations, you like to replace the fluid deficit in about 24 hours. You give half the deficit in the first 6 to 8 hours and the rest of the deficit in the remaining 24 hours. If you have a hypernatremic dehydration, you don't want to bring the sodium down too quickly because you can have cerebral edema. And so you replace the total deficit over 48 hours. Also, don't forget when you're calculating your IV fluids, you need to calculate the maintenance. So don't just say, oh, his deficit is 1,000, I need to replace that. Don't forget that this child that weighs 10 kilos, his maintenance is 1,000. You need to give maintenance too. And you always need to replace ongoing water losses so that if the child, if you're giving him, I don't know, let's say 50 cc's an hour, but they're losing 60 cc's an hour, you're never going to catch up. Or if they're losing 45 cc's an hour, it's going to take you that much longer to catch up. So you need to replace, if they have ongoing losses like diarrhea or urine losses, for an example, in a diabetic ketoacidosis, you need to replace some of those fluid losses. Okay? So knowing those things, you should be able to figure out these problems that you have there, which kind of walk you through it anyway through the numbers. I just want to show you, this is one of the evaluation. We look at skin turgor. Okay? The best place to check for skin turgor, actually, even though they're doing it over the abdomen here, is to do it over the sternum. And here, so again, skin turgor. And this is typical of the hypernatremic dehydration, what we call the doughy feel to the skin. And it's not pathognomonic, but it's very suggestive. When you go to check the skin turgor, not only is there decreased skin turgor, but it feels like dough, you should be thinking of hypernatremic dehydration. Okay? This other one is just decreased skin turgor, and it's just slow to snap back. Development and behavior, or not behavior. We said growth was an increase in size. Development is going to be acquisition of functions. So we'll start with an infant can sit up with its back straight, has started crawling, has a pincer grasp, and plays peekaboo. What age is most appropriate for this baby? So this is one way of asking you the questions of development. One way of asking the questions is listing what does this child do, and they will give you ages to pick from. And the thing about ages is they're not going to have you tell, they're not going to, don't tell the difference between a 2-month-old and a 2.5-month-old. They'll have like 4, 6, 9, 12 to choose, months to choose from and things like that. The other thing that they might do is give a bunch of this stuff within a question about something else. And you need to know, that's delayed. But what should I do next? Things like that. So that's another way of presenting the question. And a third one would be an 18-month-old can do all the following except usually they don't get asked that kind of question that much anymore. So Generally, you'll need to know the age or know that that's something wrong to help answer the question. So remember, development reflects changes in and acquisition of new functions. There's different ways of classifying it: neurodevelopmental, cognitive, psychosocial. And it's very important, and I think you have it, or we'll give it to you, is the Denver Developmental Scale. Now, how many of you have children? See, now everybody raises their hands, yeah. Okay, so those of you who have children, you can sit there and think about when your children reach their milestones. And that's going to be very helpful for the exam, okay? Those of you who don't have children, rent one, adopt real fast, go to the mall, you know. I like to go to the malls 7 months, 18 months, 2 years. Just to play a game, you know. Not where you practice. Stay on your toes, okay? And what I can recommend for those the childless ones, is get to Denver, and this is a dry subject, okay, development and all. So I like to just focus in on a couple of things in each age group that are helpful to differentiate it from the other age groups. And so we'll go through a few of these, and then you work out your own system, but we'll go through a few of these. The other thing you need to remember about development is it's a spectrum. So when you go and look at the Denver, you'll say, oh, gee, it goes from here, it goes from this month to this month. 50% of kids are doing it at this age. It's not like a child wakes up at 4 months of age and says, oh, 4 months, let's see. Breakfast, roll over after breakfast. I can start doing this now. Some children are rolling over earlier, and some children take a little bit longer. It's a normal. There's a spectrum of normal. Just like there is for heights and weights, there's also a spectrum of normal for development. So keep that in mind. Okay? We're going to go through some of the primitive reflexes. They're known as newborn reflexes. So the Moro or the Moreau reflex. These are reflexes, newborn reflexes. So by definition, they will be, for the most part, present at birth because they have to do with the newborn. So the Moro is when you stimulate the child by gently, and I stress the word gently, dropping the bassinet, or you kind of drop the baby a little bit, and they kind of fall backwards, they'll go like this. So they'll bring their arms up like this. They tend to draw their legs up, and their toes fan out like a Babinski. So the Moro will go like this. Okay? It'll be present at birth, and it disappears by 4 to 6 months of age. Most of these reflexes, if you look at the notes, will disappear by 4 to 6 months of age. The grasp. The grasp can be a plantar or palmar grasp, and it's where if you stimulate the hand, it'll grab it. It'll go like that with it. The baby, the infant will go like that, or if you do it with the foot, the toes will curl in over the pencil or the pen or whatever. Present at birth, goes away at 4 to 6 months. The rooting reflex is where you stimulate the cheek, and the baby will not only turn its head, but it opens its mouth. Why? It's going to nurse. Okay? It's basically the same thing as if the nipple of the mom's breast were rubbing up against the baby's cheek. So they turn their heads and they open up their mouths so they can latch on. Trunk incurvation. That's where if you hold the baby in ventral suspension and you run your finger along one side of the back, the baby will move its butt to that side. So if you go like that, the baby kind of wiggles to that side. And if you run it up the other side, it wiggles to the other side. And if you run it right up the back, it goes like that. Usually they pee on you too, so make sure they're wearing a diaper when you do it. The place present at birth goes away at 6 to 9 months of age, a little bit later. The placing or stepping reflex is where if you hold the baby and you let the foot, the dorsum of the foot touch the examining table, the baby will kind of go like that, like it's going to take a step. Even though it's 3 weeks old, it'll go like that. It's called placing or stepping. So you stimulate the dorsum of the foot, and they make it look like they're going to take a step. Goes away at 4 to 6 months of age. You're going to see a beautiful picture in a minute. The tonic neck reflex. That's what's known as the fencer's pose. If you lay the baby on its back, so it's going to be supine, and the head will be turned to the side, and it'll have the one hand forward like this, and the other hand will be like this, like a fencer. Okay, on guard. Okay, that's called the fencer's pose. Now, if you take the child and go like this to the head, it'll do the opposite. So you can really drive them crazy. They do that. Okay, they're going to get mad at you too if you do that. Present at birth goes away at 4 to 6 months of age. And then the last one of the newborn reflex, or infant reflexes, is the parachute reflex. This is the only one in the list that's not present at birth. Okay? The parachute is the one where if you tip the baby, they're sitting up and you tip them over, they will move their hand out in anticipation of falling. They don't want to fall. Or if you grab the baby, you go like this, they will go like that with their arms because they don't want to fall face first. So it's not present at birth. You try doing that to a 1-week-old or a 2-month-old, they fall over. Okay? It usually shows up at around 6 to 8 months of age. It should not go away. Depending on your blood alcohol level, it might go away, but it doesn't go away in normal people. Okay? So let's see some of these. Same thing, so we don't need that. Okay, so this is the Moro. Like I said, gently, and see how the arms come out around here? Now, I didn't mention the Babinski. The Babinski is the one that is... Pardon? It's normal until about 18 months. Okay? That's where if you stimulate the foot, they'll go like that. That's normal till about 18 months of age, and then you don't want to see it afterwards because it signifies upper motor neuron lesions. Okay? Okay, that's the palmar grasp. See how you put your finger there and they grab it? And this is the plantar grasp. Present at birth, goes away when? 4 to 6 months. Rooting. See how they stimulate and the baby... Present at birth, goes away when? 4 to 6 months. Good. Ah! I love it. That is one of the cutest babies. I wish... Okay? So if I were to move the head, he looks like a ninja. Hi-ya! If I were to move his head the other way, it would be like if I flipped the slide the other way. Okay? And we need to change his diaper. Looks a little bit heavy. Of course, that's the joke that the mom brings the baby in and the diaper is just full. And the pediatrician says, you can change his diaper if you want. She goes, oh, but it says it holds up to 10 pounds. Okay, so this is lack of the parachute. Okay? It's a soft padded floor. Guy knows what he's doing. He's a trained professional. There's a good parachute. That's an older child, but see how this child is anticipating its face meeting the carpet? So it puts its hands out so that it doesn't. And, I thought I had the... Oh, well. All right. So let's go through some of the behaviors that they will have, too, okay? 0 to 3 months. Now, when we talk about positionings and behaviors, these are the milestones that we talk about. We talk about prone positioning, we talk about supine positioning, we talk about all kinds of different things. So this is what we call prone positioning, and this is what we call ventral suspension. Okay, this is like a 1-week-old, okay, and this baby, it looks like a horseshoe. That's because their muscle tone is not that well developed yet. So if you put a 1-month-old or a newborn like that, that's what it's going to look like. Okay, this is more of a 1 to 2-month-old. See how the head is now a little bit better with the back, with the plane of the back? Okay. I think he's peeing too. I don't know if that's... Okay. This is what we call the head lack, or lack of. If you pull the baby up to sitting, when they're younger, their heads tend to just kind of lag behind and then pop forward. And as they get older, 3 to 4 months of age, 2 to 4 months of age, their head lag goes away. Look good. See, there's some head lag. And there's a nice, healthy... Look how this baby's looking at the face of the examiner. Okay? And you remember your baby's doing that, right? Sure. Okay. And this is a newborn, and if you put them in the prone position like that, they can just barely get their faces over to the other side. Okay? And they will probably rub their noses a little bit. Now, my nose is big. I would probably rub it a lot. Okay? I'd have to get my head up even higher. This baby is about 1 week. This baby is about 1 month of age, and now when this one picks up its head, the whole face will clear the exam table, and it won't rub on anything. And this guy's about 4 months of age, okay? Look, he's literally ready to roll, okay? He's got his arms underneath. He's got his chest up, and the head is still kind of big and heavy. So all he has to do is push himself a little bit, and the weight of the head, boom, he'll roll over. So he's ready. He's about 4 months of age. So when you look at these things here, I think I got a couple more. Yeah. Oh, you're doing better, girl. Okay? Didn't tip over this time. Kind of a little tripod position. This is about 6 months. There's a pincer grasp, a good pincer grasp by 9 months of age. See how he's picking up the little Cheerio or whatever? Okay, so that's enough pictures. So let's go over the tables here. So a newborn will turn its head, its nose touches, and on ventral suspension it will be flexed around the hand. On supine position, they will be flexed like a newborn is, like I showed you that term newborn baby, and they will have visually, they prefer a face, and they have doll's eye movements. At 1 month of age, they will clear the surface of the exam table and not rub their faces on it. And they can lift their head to the plane of the body. And they will follow a moving object. Usually what they call the social smile shows up at about 4 to 8 weeks of age. By 2 months of age, they can lift their head and chest in the prone position, and they can keep their head in the plane of the body before it, for a while, and then all of a sudden, comes back down. They will have the tonic neck still. They still have a head lag at 2 months of age. They will smile on social contact at 2 months of age, and they will coo. That's one of the things I look for. Cooing at 2 months of age, oh, you're all right. By 3 months of age, they can lift their head and chest from the exam table. They still have the tonic neck, and they have the social smile still. And you have a list. I'm just not going to read them for you, but I think you should pick out certain things that stick in your mind. These are the ones that stick in mine, and then but we'll give you a Denver developmental also. Okay, remember at 6 months, this is an important one. At 6 months, they usually roll over from 4 months to 5. At 4 to 5 months, they will roll over from their stomachs to their backs. At 5 to 6 months, they will roll over from their backs to their stomachs. It takes more muscles to do that, more tone. Okay? But at 6 months, remember that they can start creeping or crawling. Okay? Creeping means that they're just pulling themselves along. Crawling means that they're going to start using their legs to push themselves along. Also, an important one at 6 months of age is the sitting with pelvic support, the back rounded, and leaning forward on the hands like that little girl I showed. Also, raking at a pellet. Raking at a pellet means that they just go like this. They don't have that pincer yet, but if you put a pellet or a raisin or something, they'll go like this, and then they'll kind of bring it in. Raking, okay? At 9 months of age, they'll sit all by themselves. They can creep and crawl and sometimes walk with their hand held, 9 to 12 months of age. Pincer grasp is really good at 9. And they'll play peekaboo. So this baby that they described in the question has crawling, pincer grasp, and plays peekaboo. That's a 9-month-old. Okay? At 12 months of age, they have cruising. They may walk a little bit. Cruising is when they walk holding on to things. So they'll hold on to the coffee table and move a little bit and then go like this a little bit more and a little bit more. That's called cruising. Every once in a while they kind of give you one of those to let go and then they go like that again. Okay? And remember, also an important one for me at 1 year of age is when they adjust their positions. It's easier to dress them, you know? Because before that they're all like this and you got to stretch an arm out. This way they help you out a little bit. 15 months of age, it's important to know that they're walking by themselves. And the large object, now I see how we've changed, go to large objects. Well, I think the towers drive me crazy, but the way I figure it out is the ages are 15, 18, and 24. And the towers, you start at 3, then 4, and 3 plus 4 is 7. So it's 3, 4, and 7. Okay? Remember also at 18 months, no is a favorite word. They know about They know body parts, they know about 10 to 20 words, and no is a real good one. Okay? And then by 24 months of age, they're starting to put sentences together. 30 months of age, that's an important one. That means that they will start walking up the stairs, but they are alternating the feet. So, I got stairs right here. So, normally, before that time, when they go up the stairs, it would go like this. Okay? But now, they just alternate. They go like this and then like that. They alternate their feet. 36 months, they can go down the stairs alternating feet. So 30, they go up alternating. 36, they go down alternating. And they know their age. Usually they're 3 years old. And they can tell you that they're a boy or a girl. And then remember at 48 months that they can copy a cross or a square. 48 is 4 years, 4 sides. And they can count 4 objects. Very important. All right, so those are some of the things that I use to kind of help remember. Attention deficit. Attention deficit hyperactivity disorder. Okay? A 6-year-old boy is doing poorly in school. Teachers report that he is distractible, impulsive, and fidgety. Parents state he is always on the go at home and has been a discipline problem. Okay? So the abbreviation is ADHD. Now, the hyperactivity part is not always there. They can have attention deficit without hyperactivity or with hyperactivity. Usually with hyperactivity, it's more boys. It's more common in boys, period, but generally with the hyperactivity, it's definitely going to be boys. Okay? So, it's characterized by an inability to attend to the task at hand, increased motor activity, and impulsivity. They're very fidgety. They're always like their foot is moving, or they can't sit still, or they're looking around. Everything distracts them. And we really don't know what causes it, but we know that they do have problems filtering stimuli, so that the guy that talks over the loudspeaker irritates the person, or the light bulbs, or the birds singing outside the classroom, and that child, every little stimulus, they're not filtering it well, and so they're looking at every little stimulus, and that they're not paying attention to the teacher. Okay? They also have problems controlling their own behavior to socially acceptable norms, and that has a lot to do with the impulsivity. Again, it's more common in males, and you have your criteria there, the DSM-4, or inattentiveness, and inside the inattentiveness you have mistakes because they don't pay attention, difficulty paying attention, doesn't seem to listen, doesn't follow through on tasks, difficulty getting organized, avoids sustained mental effort, loses things easily, distractful and forgetful. Hyperactivity, they're fidgety, they're out of their seat, they don't play quietly, and in the impulsivity is they just say things, they do things without thinking about the consequences. And there's no test for this. You can't just, you have Connor questionnaire, you have all kinds of different things. There's no tests for this. You do have to fill some of these criteria, and they're listed there. Okay? So what do we do about it? Well, you can do pharmacologic treatment. You can do psychosocial management. You need to treat the family. It's very difficult to have a child who's getting into trouble all the time or doing this at home. I mean, you can see them in your office for half an hour. Imagine them at home all the time. So a lot of different things need to be done, and the family needs help too. The drugs that are if they have an associated learning disability, that needs to be managed also. And medications include methylphenidate, dextroamphetamine, pemoline, tricyclic antidepressants. There's more and more being used all the time. Diet has nothing to do. Okay, red dye number 2, chocolate, sugar, that kind of stuff, forget about it. Really doesn't have anything to do with management of ADHD. Complications. Some patients will outgrow this. They learn to filter out things. They learn to overcome the distractibility and the impulsivity. They kind of learn to control some of these things. A 7-year-old boy has problems with bedwetting. Mother says that during the day he has no problems, but is usually wet 6 of 7 mornings. He does not report dysuria or frequency and has not had increased thirst. So these are important things because it's eliminating some of the organic causes, okay, like diabetes, like urinary tract infections, things like that, okay? Mother also says that he's a deep sleeper. And there's also something very important in the question that it's a boy, okay? So enuresis, in this particular question, this is nocturnal enuresis, a disorder of arousal and sleeping, okay, for the most part, okay? Enuresis is defined as you're having involuntary passage of urine after a normal age for toilet training, which is usually most children are trained by the time they're 3, but certainly by the time you're 5, if you're still having problems wetting the bed, that's enuresis. And every year, there are fewer and fewer children with enuresis as they get older. So that's another thing to reassure the parents. That does run in families also. So keep that in mind when you're reading the question. And here it doesn't say that, but it does say a lot of things that go along with nocturnal enuresis. Primary enuresis is the child that's never been dry for a significant portion of time. Secondary enuresis is the child that has been dry and now starts having accidents. And that's the one you have to pay attention to as far as is there something going on at school, is there something going on at home, a bully, a new sibling, parents are getting a divorce, grandpa died, something like that. Nocturnal enuresis is associated with maturational developmental delay of the bladder. You are going to look for a child with nocturnal enuresis, a child that does not have problems during the day. So when you're reading the question, if he's not having problems during the day, it's only happening at night, that's probably what it is, especially if it's a boy. You do need to worry about urinary tract infections, diabetes, things like that, which may be causing problems with enuresis. Okay, encopresis is fecal incontinence, and it's usually more common in males, and it's usually psychological, toilet phobias, and constipation. You don't want to go to the bathroom at school, so you hold it in, and then you get impacted. And then you have leakage around the impaction. Or you've had diarrhea and now it hurts, or whatever. You had painful bowel movements. These are things that trigger encopresis. You want to have voluntary withholding, and then usually you will have some leakage around it. Okay? And the treatment consists of counseling and many times cleaning out the patient and starting all over again. So you clean them out and then you start all over again. And the last thing is the developmental disorders such as autism. A 4-year-old child speaks in unintelligible mumbles, prefers to play by himself, and rocks back and forth constantly. Parents state that as an infant he had a delayed social smile and was never very playful or interactive. So this is where these developmental things that we went over, that you have to pick some out, that might come in. They may not say it flat out, he had a delayed social smile. They might say he didn't start smiling until such and such an age. And, oh, that's kind of late. So that's where the developmental part can come into this kind of question. So autism is a developmental disorder, and it's usually a problem with social relations. Okay? They also have verbal and nonverbal communication deficits. And they have unusual responses to their environment. Usually you'll pick it up before 30 months of age. You know, ADHD, many times you don't pick up until kids are in school, because that's the first time that you're putting real social constraints on them as far as being in another group. But autism is usually picked up a little bit earlier because of these things with the delayed social smile, the speech, the repetitive behaviors. You'll pick them up earlier. Clinical features include, and again, a lot of this stuff is going to be retrospective. The mom looks, you have to get a good history. Failure to attach as an infant. A delayed or absent social smile. What they mean by failure to anticipate interaction is you go to pick up a baby a 9-month-old sitting in the crib, and you go to pick them up, and they go like this. They're waiting for you. And these babies are just laying there because they just don't have that social interaction. And that's something that will show up on the exam question. They may have delay in verbal and nonverbal communication. They may not communicate much at all. They tend to have repetitive movements. They tend to sit in the corner. They may have a need for constancy. Okay? They can have outbursts of anger. They can hurt themselves and other children or other adults even as they get older. There's no cure for this, and treatment consists, again, of small groups, educational programs in small groups, and sometimes you can use pharmacotherapy, and the prognosis is very poor. Asperger's is kind of like a subset of autism. They are more communicative, they appear more aware, and they don't have, so we should fix that, they do not have the language impairments that are seen in autism. However, they do have social impairments, they do have repetitive behaviors, and they have obsessional interests and constancy too. So it's almost a subset where it's like an autism with more verbal skills. That's how you can look at it. Okay? And the last one is Rett syndrome. Only females, X-linked, dominant, and usually they're normal until 1 year of age, and then they start losing milestones or delay, and their head stops growing. And very important to remember what's known as hand-wringing and sighing. Hand-wringing, they do a lot of hand-wringing behavior, and sighing, and maybe almost like autistic.